Okay, you can hear me, great. Ladies and gentlemen, dear friends, a very good morning and welcome to the forest. This is Sweden in Dubai for these 6 months, and we are extremely proud to have this platform to collaborate and find areas of collaboration and partnership between Sweden and UAE and beyond. We do have an extremely exciting program today. We will start off with our quarterly business breakfast briefing, which is a way to gather the Swedish companies management in a room together with the embassy, the Expo, to discuss current affairs, challenges, opportunities, and become a team, as a team Sweden, to support each other. So we will start off discussing the Expo. Our participation so long and check-in is almost 4 months into the Expo. Only 2 months left. Is going extremely quick, I have to say. And if you look at the Expo, then the investment that is done by the companies and the Swedish government, this is the single largest investment ever done to promote Sweden. This is a great platform to utilize going forward for us who will be here after the Expo, and making sure that we are taking the advantages of this platform. We need to conclude this session by almost 10:30 before we start the second part of this program, which is talking and discussing about the future of healthcare, connected health, which will be then broadcast live at 10:30. Again, we are living special times. Just a reminder about to keep the mask on when we are in here and try to keep the distance. With that, I thank you for coming here. We expect some more people to join us by 10:30 as well. But I'm extremely happy to hand over to our permanent Commissioner General, Mr. Jan Tesleff, who is heading our activities at Expo 2020. Jan Tesleff is a seasoned ambassador, been living in the region for a long time, and he's extremely pro-business and an extreme promotion for a business community. So Jan will share his experiences and insights during the first 4 months, and perhaps give us some advice how we can take this further going beyond. So Jan, welcome to your stage. This is your home.
Good morning, everyone, and a warm welcome to all of you, and thank you, Masoud, for your introduction. So if this is the forest, then I guess, Masoud, you are the king of the forest. And I'm very excited to be here with you today because of the business breakfast, but also because of the following topic, the connected health. As you know, we are heading into the Health and Wellness Week. We're expecting a very heavyweight delegation of Swedish life science companies coming here as from Monday next week. So this is a little bit of a first taste, so to say, of what is to come. We are very happy to have Professor Claude Marcus with us, and Professor Marcus Lingman with us in person, and I know we have other digital participants also. So indeed, a very interesting morning. Also very grateful to Dubai Health Authority for being here and to give us the insights when it comes to awareness, prevention, and of course access to healthcare through data, through new technologies. But I thought of starting off a little bit on the track where Masoud put me. And it's mind-boggling that we've gone through 2/3 of the Expo. Actually, we had so many odds against us. The Expo had been postponed 1 year. Everyone had to reinvent what they were going to do. We did the same. And we were struggling to open on the 1st of October. We got ready on time, and we opened. If we looked at the world around us, most people would have said, especially looking back at the Olympics in Japan, that a physical event like this one didn't stand much chance of succeeding. Now we are 2/3 into the Expo. More than 10 million people came in person to the Expo. And we are so encouraged that 5% of those who visited the Expo so far came to the forest, the Swedish pavilion. And for me, let's not dwell on statistics too much, but 192 countries. And it is important to remember that this is a global event centered on Dubai. So 192 countries. And when I took on this job, or when I was asked to take on this job, I must say I was not too familiar with the World Expo history, and it's actually a family. I mean, there are people who do this for a living, and they have done so since 1851. Maybe not the same people, but since 1851, when the first Expo was held in London, Crystal Palace. And most visitors, tourists to Paris maybe don't know that the Eiffel Tower in 1889 was constructed also for a World Expo. And somehow this building where we gathered this morning is quite symbolic of what expos are about, because expos throughout history have had the mission of showing the latest technologies, the latest technological advances, scientific advances. It could be steam engines, or it could be artificial intelligence today. And they also had another mission, and that is to inspire hope. And I think that the great country of the United Arab Emirates has actually grabbed both those aspects, but especially the hope aspect. And I would say that this World Expo here in Dubai has another significance today than it would have had without the worldwide pandemic. I think it really has it's a slogan, when the world gets together again. But it's not only a slogan, actually it's true. This is the first time many people meet again in person. And we see it when it comes to the high-level visitors that we have invited and that have responded to our invitations and come here to the Expo to be here to support Swedish business, Swedish nation branding. We've had ministers, we had His Majesty the King of Sweden. In December we had a delegation of over 200 people who, despite all that's going on in the world around us, they were staying the course and they came. Beginning of the year we had also our first ministerial visit. We have another 3 ministers in pipeline until we closed our doors on the 31st of March. And we also have other high-level visits, non-political high-level visits in the making. So somehow this is unique from that perspective. There is also something else that is unique, and Masoud, you touched upon it. what happens here now is temporary. Our Expo participation is governed by a committee, and I'm working for that committee, and that committee one day will be dissolved. But there are some things that won't be dissolved. The Swedish Business Council won't be dissolved. Business Sweden won't be dissolved. The Swedish Embassy will not be dissolved. They are the permanent features. And not everywhere in the world do we have a business community as solid and as successful as I think that Business Sweden will tell you a little bit later when we look at the trade statistics for our trade with this country, but also with other countries around. So that is actually the base that we will continue building on. What is so unique about the Expo, and what's so unique about this building is that it's has never happened before, I think, that we have a home turf on one of our most important markets. Not only the UAE, but global market. Normally, when we travel abroad, or when delegations come, or companies come to visit, meet authorities, etc., they go to the ones that they are here to meet. They go to their companies, to their offices, to their ministries, to their authorities. Just for once, during 6 months, we have a place, a base, to invite them to come to us. And that is something unique. It's as if the world traveled to Sweden, or as I sometimes say, pop-up Sweden in Dubai. So that aspect is something I really would like to plant in your mind, that is something very, very unique. And when we can use the microcosmos of the Expo, when we can make use of the 192 countries present here, like we did during the Saudi-Swedish days, that we will do during the Egypt-Sweden day, like we will do during the Pakistan-Sweden day or India-Sweden day, that's when we really can benefit from the microcosmos, from the world that is present here. So what I would really invite you to do, I know that some of you are partners to us, some of you are sponsors of us already. 143 Swedish entities, companies, authorities, organizations actually went in since 2018 to support this, as Masoud said, the biggest Swedish engagement to promote Sweden abroad ever. No world exhibit before, not the one in Shanghai, no Olympic Games, no fair in Hanover or somewhere else has ever had the support that this engagement at Expo 2020 has. But if you are not, if you maybe discover this platform now, maybe through visits before or even this morning, you can benefit from this platform. We have 2 months to go. There is a possibility to come and do an event here. You can do an event in this room, you can do an event upstairs on our roof terrace or in one of the smaller rooms. We are heavily booked. Some periods we are almost overbooked, but there are still time slots available. So if you feel that this could be something for you, please come to us and we can discuss. Normally, when we talk about sustainability, it's actually an overused word in my mind or in my vocabulary. We use it without really thinking, what does it mean? And for me, sustainability, which is at the core of this building, and if you have the time, go through the exhibition and you will see how we portray it. We portray it through method and through process. which really makes this pavilion different from many others. Less the final results and more, how did we do it? But sustainability, to me at least, is like economics in a way. How do you satisfy needs today without compromising the satisfaction of the needs of tomorrow? Quite simple. Or maybe common sense. What I think is so important is that we make use of what is unique. And I think when you have something in front of your eyes, you might not always see it as well as you do when it's maybe from a distance or when you look at it in another way. Especially this building. I had a visitor that came the first week, and she said, "It's a fantastic building, it's a beautiful building, but when will you paint it?" And then I thought to myself, our narrative will be so important. What is behind those walls? What's under the floor? And actually, if you look under the pavement or the paving in the exhibition, you will find that it's wood on sand and crushed glass. But we took away the cement, we took away the steel. So it's wood on sand, and that makes this building so unique. Of course in the UAE, of course in this region, but actually it makes it unique beyond. If you look at the energy solutions that have been chosen, or the engineering solutions, they're also unique, but you have to look behind the wall. And if you can't look behind the wall, we have to tell the story. And I will end by saying that I think that for many of us, depending on what business you are in, and I know you are all successful in your own fields, be it in business or research or whatever, but how can we make the invisible visible to those, our contacts, to our clients? I think that is the challenge, but that's what we can do in this pavilion. That's the seeds that we can plant now that can be harvested by you, together with Business Sweden, together with the Swedish Business Council, together with the embassy, and of course other actors too. So I think there's a fertile ground here. Make use of it. Interact with us. We want to be part of making the new business as unusual for Sweden, in UAE, but also globally. So thank you so much for having me here this morning. We are at your full disposal. We are a total of 135 people working for this project. 52 of them work directly with me, and others are providing different services to us. But feel at home in the forest. Thank you.
Thank you, Jan. Inspiring as always. History shows that every region has a decade that they are blooming, and we strongly believe that 2020 to 2030 will be the decade of Middle East. Looking at what reforms and projects is ongoing in the wider region, we are certain that Middle East will be the center point of the world when it comes to investments into change. And the UAE is in the center for that. Again, the aim of this morning session is really making sure that we are utilizing this platform going forward together as the Swedish community. And we know that Swedish businesses has been for a long time, and looking at the plans for the UAE for the coming 50 years, where they will go from an oil-based economy to a knowledge-based economy, where a lot of Swedish strengths are. We believe that we can and have a lot to offer. It is up to us to make sure that we are partnering up with the UAE to support and find the areas of collaboration. Briefly, what we see here is the relationship that's been built for over 50 years between Swedish companies and the UAE. As Jan mentioned, during those 4 months so far, with 192 countries presented here, we have had many ministers' visits to the Swedish pavilion. Everything from Brazil to Malaysia to India, Russia the other day. And they are looking at Sweden because Sweden is ranked as one of the most innovative countries in the world. And looking ahead, we have, with our innovation power, a lot to offer, and they are looking at us and they are seeking our partnership. As mentioned, UAE is one of the most important country in the MENA or MESA region, Middle East, Africa, and South Asia, where 30% of the Swedish exports goes to the UAE. This is the second largest export market for Sweden after the Kingdom of Saudi Arabia, almost in par. Based on the discussions with the government representatives, Sweden has a strong trust. They look at Sweden as a trusted partner. We provide quality and we keep our promise, and that's something they value very, very high. Just briefly mention the last point, as we've seen the development with the in-country value, which is regarded as an important component in the relationship doing business with the UAE government. We from Business Sweden, together with the embassy, we have conducted a survey when it comes to the in-country value in order to understand what are the Swedish businesses contributing to the UAE economy. And for us, it's important to have that information and convey that message every time we meet them, to really, truly show them that we are a partner, we are contributing to the economy, and we want to be doing so going forward as well. It is a quite I can briefly just show you the criteria for that. When it comes to the in-country value, they will look at how much you invest into the country. Emiratization obviously is a big point, an important point for the UAE on their agenda. The contributions overall to the country, and this will be even more important going forward. And again, we strongly believe that we have a lot to offer with our innovation power and the knowledge that we have, because the business of trading, which we historically, they are buying a product or service, you get paid and you move on. That time is over. They're looking for partnership. They want to be a long-term partner with the Swedish community, with Swedish government, into understanding, getting the knowledge over, and in that transaction you also obviously are providing the services and products. As mentioned, the export has been growing over the last years. We can see that 2020, despite the pandemic, was again a record year for the export from Sweden to the UAE. The numbers for 2021 is not yet concluded, and we are looking forward to see those figures. But I would be surprised if the growth didn't continue. Based on the survey that we have done, we can see that over 1 billion dirhams has been invested by the Swedish companies directly or indirectly into this country. We are providing jobs, 15,000 of those in the country, and we have about 200 Swedish companies presented directly as their own legal entity or indirectly through distributors or partners. I think I'll stop there, given that we have time constraints to focus on the next session. But our aim and ambition is to have a session with all the Swedish community before we close the door, the 31st of March here, together with Jan and his team to really taking the insights, the learnings, and how we can, together as a business community, use that information and plan ahead. Because we have a lot to offer, and the UAE government are surely looking for our partnership. We will be reaching out again and collecting this data when it comes to the in-country value. And I really, truly hope that you will be supporting us to collect that information, because it is important to convey that message to our partners here locally going forward. Thank you for that, and thank you for listening. I don't know where we are with time. 6 minutes. Great. If there are any questions here and now, I'm happy to take those now. But again, you will be hearing from us. Try to gather everyone here by the end of March to conclude our understandings and learnings from these 6 months. Now we will switch over to the exciting future of healthcare, and I'm extremely proud and pleased to have Professor Claude Marcus, Dr. Marcus Lingman, and Dr. Khulud, and many here with us physically, despite these times and the COVID going on. We will be broadcasting this session from 10:30 as well. We have quite a few listening in, both from Sweden and elsewhere, quite early in Sweden. So thank you all for making the effort and coming here. I'm looking forward to these sessions and understanding about the future of healthcare, where again we believe Sweden is in the forefront and has a lot to offer in collaboration with our local stakeholders and beyond. The master of the ceremony, or the moderator of the day, will be my dear colleague, Dr. Britta Stensson. She will be moderating and keeping us all alert, I hope. So, Britta, please welcome up to the stage. The scene is yours.
Thank you. Can you hear me? Should we start now, or should we wait until 10:30 for the broadcast? I'm looking for organizers. Perhaps we should wait a few minutes. We've promised to broadcast live at 10:30, so I think we should probably give it a few minutes. den som är sist. Ja, precis. Ja, men då ska du bli mickad sen till den. Ja, då bara att du går, säg det till teknikerna där, att det är du som ska bli mickad till den, så vet de om att det är någon annan. Mm. Okay, great, let's get started. So thank you everyone, and welcome for us joining here at the Swedish Pavilion and everyone joining online at the live stream for this very exciting half day on the future of connected health. So let's get started right away with our keynote speaker. He is a medical doctor and a cardiologist, a chief strategy officer, and a researcher in information-driven care. He was appointed the AI Swede of the Year in 2020, and last year he was also the main author of a handbook of information-driven care. So please welcome Professor Marcus Lingman.
Is there a clicker?
Yeah.
Okay, thank you. Thank you for inviting me to Sweden in the UAE. It feels very at home, actually, to be here within all the wood. I will have the opportunity to introduce the notion of information-driven care in relation to connected care for a few minutes now going forward. A few weeks ago, we could read this. The first drone delivering a defibrillator to support a patient with cardiac arrest, saving his life, is official. Astounding news, but only a part of the healthcare system, or rather the healthcare ecosystem that is developing. So we're transitioning from a very traditional brick-walled healthcare with hospitals, primary care, into an ecosystem that is fairly fragmented but very diverse and heterogeneous and very close to you and I as patients. And more actors are getting into this ecosystem. And what we know is that once we get to keep this ecosystem as one system, working together around the patient, around the individual, it saves lives, in contrast to a fragmented system where the different parts are not working together. And the glue is information. The glue is information stored and utilized as data. And that is one of the topics for today, making use of the data so that we can deliver better care as an ecosystem together across nations and within nations for the patient. And that glue, the amount of data, is increasing exponentially due to all the sensoring, the diagnostics, the new fancy machines that can measure the inner self of you, your DNAs, your exposomes, your proteins, whatever is in there. And all this information, or rather the data, can leverage your health going forward on the individual level, but also leveraging the ecosystem in order to make better care as a society. Working alone on this sometimes difficult topics is not a good idea. In our system, we had the opportunity to work across the sectors, across the industries, to learn from each other. We have, during the journey that I will speak a few minutes about soon, a great collaboration, for example, together with Volvo, who is developing self-driving cars. So what has that to do with healthcare? Hopefully I will explain that in a few minutes. But also great companies like Spotify, who works with AI, applied AI all the time in order to understand how you exactly as an individual consume music. What does that have to do with healthcare? Well, partly using data in order to profile your specific needs. And that's where AI comes into the picture. Sometimes I say that AI was developed for healthcare. That's certainly not true, but you can almost think that that could be true, since AI is good at pattern recognition, which is basically diagnostics to a clinician as me, or prediction and prognostics, which is risk identification in healthcare. So identifying what's going to happen beforehand and seeing patterns that are difficult to see in all this complex data in ever increasing complexity of the healthcare ecosystem, that's where these advanced tools have a natural place, going from descriptive medicine, where we see what's happening right now, to predictive healthcare, where we see what's going to happen so that we can prevent it from happening in the first place. I come from a region in Sweden, an accountable care organization in southwestern Sweden with almost complete array of care delivery, including primary care, ambulance care, hospital care, etc. And we have committed to work according to what we call information-driven care today, where we systematically use the data from all across the healthcare system to translate it into information. The data has to be translated into information in order to make sense, so that we can get new insights. The data in itself is not worth much, and the translation into information is that worth very much if it doesn't create new insights that are actionable and that you can use to alter behavior that eventually creates better care for patients, because that is the goal, to provide longer lives and better health. And in order to do that, we gathered all the data needed in one specific warehouse, not only EHR data or clinical data, but also resource data and HR data and all other aspects of healthcare that needs to be there in order to understand how to build secure and efficient patient trajectories, patient pathways across the entire healthcare ecosystem, where all these pieces in the puzzle are working together. And when you have these capabilities, you can apply machine learning methods, but you can also apply variability analysis in order to see where exactly, data-driven, that you can improve healthcare for the patient across the care chains, and also do adequate return on investment calculations, so you know that you invest in the right stuff. But it's not a good thing stopping at the data, as I said. So we also created what we call the Center for Information-Driven Care, somewhat like the Tower of Power, the command center, the flight tower, where we can see this happening in the data using machine learning, but also more basic business intelligence methodologies. And that's what was one of the early insights in our development together with Harvard Medical School and Harvard Business School, that should be acknowledged in this setting, that we needed to complete the usual business intelligence methodologies with data science. And that's something that healthcare is not very used to doing. But we also needed to add the resource perspective to the analytics. We have limited resources. We need to use them as well as possible. And there was no accounting method that complied with our needs at the time. So we, together with Harvard Business School, we developed ways of understanding resource utilization across the patient pathway, every single encounter, so that we now can see when we make a change in the patient pathway, we also see the effect on resource utilization on the systems level and on the individual level. And just to give you an example, when you have these capabilities, you can understand that you can invest in some seemingly quite expensive, in this example, pharmaceuticals, while returning on investment is still positive on the systems level, because the investment reduced cost in another part of the ecosystem, which is not identifiable if you don't have the overall view. And working with this, you can sort different initiatives, different ideas, and relate them to each other in order to understand where to put the effort in the development of your healthcare system, what to invest in, what sources of value for the patient that will have the largest effect. And you can also use AI to realize that we as humans are biased and support our thinking to becoming more rational, if you wish. We know that we over and under examine patients. We investigate the wrong patients. That we can identify using AI. We use oversimplified models because they're easier to understand. And we put too much trust in readily accessible information describing stereotypes. We treat patients on the group level. We oversimplify the world. With the help of all these tools, we can go towards precision medicine, or rather precision healthcare. And in Sweden, I'm happy to live in a country where we collaborate greatly around these topics, together with patient organizations, industry, academia, healthcare, and government, pushing the issue forward to reach a situation where we can meet our mutual and common challenges in healthcare with increasing demand by going towards predictive precision healthcare. So we'll stop there and leave the word back to you. Thank you.
Thank you very much. I will definitely quote you on the AI was developed for healthcare, especially when talking to other AI people. We will invite you back on the stage for the second panel. But right now we are moving on to our first panel, which is the topic of improving patient outcomes with the help of new technologies. And to get us started, we have a keynote speaker who is the head of clinical standards and guidelines and a consultant at family medicine at Dubai Health Authority. Please welcome Dr. Khalud Al-Sayegh.
Hey, okay. Have a presentation on?
Yes, I think it should come up. The clicker is right there.
It's not yet. No.
Oh. It's here. Yeah.
Okay. Hej, god morgon. Jag heter Khalud, jag är läkare och arbetar jag på hälsoreglering. Jag har fått lära min svenska i 4 månader. Jag hoppas att ni gillar min presentation idag. Thank you for coming today. I would like to use this opportunity to thank the leadership of the UAE for all the support they have given us in the healthcare system. I would also like to thank Business Sweden for inviting me for today's presentation. I'm going to start the presentation with this complicated yet colorful slide of the UAE key milestones in adaptation of telehealth. The yellow boxes, they reveal the federal laws and regulations, and the other colored boxes are the different authorities in the UAE that are involved in telehealth. So if you see, over the past 10 years, we have done in the UAE multiple steps and initiatives towards the adaptation of telehealth. And in particular, the last 2 years in the UAE, we have established the standards for telehealth, and for the very first time prescribing telehealth, prescribing through telehealth for the very first time in the UAE. We've also launched our very first governmental platform, Doctor for Every Citizen. This is a governmental platform as an initiative by His Highness Sheikh Mohammed bin Rashid Al Maktoum to provide telehealth services to all UAE citizens over the clock. Now, what makes us successful in the UAE is not just the launch of Doctor for Every Citizen, but it's our continuous engagement and involvement with our stakeholders. And we are always providing focus group discussions, surveys, engaging with our healthcare providers, and empowering our patients continuously. We are also always involved with our key partnerships, for example, like the Ministry of Health, TRA, which is the telecommunication regulatory in Dubai, private sector. We're always involved. We all speak the same language so that the communication of telehealth has always been seamless. Now, prior to the pandemic, we have implemented telehealth in the UAE fairly quickly, and we've always working on the mechanics of evolving it into the better aspects. At the beginning, our focus is how to increase the efficiency of the pathway of telehealth. But when COVID came in place, we had to rethink these pathways to see how can we increase the adaptability and how can we make it more accessible for everyone in the UAE. And therefore, we have made our platforms more simple so that it can be adopted easily. We have done accreditations, telehealth policies, as well as telehealth guidelines. We have also involved in key indicators, key monitoring indicators in order to see how things go. And since the pandemic and the curve, you'd see that the adoption of telehealth has increased and the curve went upwards. And there's an increase in the utilization of teleconsultations on the Doctor for Every Citizen platform, making 83,000 consultations during the pandemic, which is a huge success for the UAE. Now, moving forward in the UAE, what do we see? We have to think really bold and out of the box on how we can provide care radically, and we have to provide care to our patients equally, and at the same time have cybersecurity. So we're looking to home hospitals, and what I mean by home hospitals is bringing healthcare back into the houses so that patients have empowerment and are able to have that concierge service at home. We're looking into having hospitals without walls. I mean, why do we have to see hospitals in a circumcised physical space behind walls? It is embedded in our lives. I mean, look at the situation right now. Healthcare is the health pipelines in the airports and schools. We are doing the swabs everywhere. So this is how we are picturing the future of telehealth in the UAE. Beyond the borders, as in we want to see telehealth consultations going abroad as well, like having consultation from experts in Europe and from the States, and without having to interfere with the current laws and regulations. And we're working on the mechanics of that continuously on how to do that, and then, the scalability of it. So increasing things like, for example, tourism in the UAE, which is a great asset and a great revenue for the UAE. And finally, towards healthcare sustainability, we have that green spin when it comes to telehealth on how we can reduce the ecological factors and improve sustainability in the UAE. That's my presentation for today. Tack så mycket.
Thank you very much. Please take a seat. You can sit over here. Thank you. So let's welcome the rest of the panel. And joining us here in the room, we have Dr. Masoud Yadidi, who is the Executive Vice President International at Imagine Care. Oh, there you are. Come on, let's sit over here.
You?
Yes, right here.
Thanks.
And then we also have 3 panelists joining us on link. Let's see if this works. We have Dr. Nasim Bergman Farouknia. Yes, there you are. Hello. You are the chairwoman of eHealth Doctors Association in Sweden. And then we have Anders Sonesson, general manager at Gloco. Hello. And Dr. Masin Gadir, digital health innovation principal at IQVIA. Hello. Great. So,
hello, how are you?
Let's get started. I'd like to ask each and every one of you, from your point of view, what is the biggest impact new technology can have on patient outcomes? Would you like to get started?
Yeah, I can start it. Thank you very much to be here, and thank you, Business Sweden, to invited me for these very interesting topics to discuss. I'm very happy everybody touching a very important subject, which is the access to their care. I think you know better than me that chronic diseases is one of good example, taking a lot of resources at the hospital. The cost is very high. In general, the average of the cost of chronic is 85% of the entire healthcare cost. So if we look at US has 50% of the people have chronic diseases. 50 million people in Europe have chronic diseases. So everybody knows those challenges. I'm not going through the challenges, very clear, but the solution is starting very slow going inside. And we are talking about access to the care. So number of the beds in the hospital is not any good reference anymore for healthcare system. So I think screening of the patient at home, what you mentioned is perfectly clear that we need more accessibility of care at home, at school, and I'm very interested in discussion with Professor Marcus about the access to the data. Today we have a very clear picture of the patient at the hospital, but we don't know anything about the patient at home.
Yeah. I see you, Dr. Farouknia, you are nodding. Do you want to comment?
Yeah, thank you very much. I'm so honored to be here, and thank you very much, Dr. Khaloud. It was beautifully presented from you. You know, and thank you. May I just share an example from my own son? You know, can you see this? This is a very kind of simple gadget to be able to measure the lung function. This one was given to my son. He's 16 today, but 5 years ago, around 10, 11, you know, he has he needs daily to deal with his severe allergic asthma. And before this asthma tuner to measure the lung function, there were a lot of kind of emergency visits to the hospital and in hospital care. And when he was given this one, because this one talks to his smartphone, of course, so he can measure his lung function, and he could kind of understand the connection in between using his medicine or different things that happen, because there is also a diary with a lot of questions in the software attached to this hardware. And, you know, we can easily log into the system, his parents and also his doctor, the generalist at our physical unit close to our home, and also his asthma specialist at the hospital. So in this case, we share the data, he understands it, and we can help and support him. And he's only a kid, so this is easy to use. And, you know, someday when we realized, oh, we haven't been to the hospital, he feels good and he can participate in daily life activities. I mean, doing his football and so on. And then he just said, Mom, you know, I've been friends with my asthma. Isn't it so? And, you know, it's kind of things that a child can say and a mother can be very happy. And I'm also a doctor, so I understand this one helps us all to help him to manage his asthma.
Thank you, and thank you for sharing such a clear example. Mr. Sonesson, would you like to weigh in? What's your take on this?
Yeah, I'm coming more from the diabetes side and access to data and so on as well. It has been an issue for a long time, but I think it's being better and better. And once we have also that development in that area with a lot of less expensive sensors and so on as well. So we have seen a lot of more data. I mean, from 2005, we were happy if we have 4 blood glucose meters from, or blood sugar readings from a patient. Today we have 2 per day. With the sensors today, it's more or less closer to 300 data points per day. And if we have that data accessible for clinicians and patients, you can do so much more and much more understanding of the patient's situation. So that will also give a good opportunity to change new care models and a lot of to do in the adherence area. That's still we have talked about that for 15 years in this in this company with all the different business models and so on. But it's still a huge area of improvement that we can do there. But very much, we have a lot of data, we have a lot of accessibility, and just making it right to the right place. That's a huge opportunity we have.
Yeah, thank you. And Dr. Gadir, would you like to add?
Absolutely, absolutely. So basically, what I think I want to emphasize the great initiatives that are happening, specifically in the UAE, making it a way of life to learn from the experiences around the world. The talented multilingual Dr. Khulud has shown that we are working here to try and drive accessibility, equitable healthcare service provision models. Having lived in the UAE for 43 years, the transformation of the healthcare system across the whole UAE has become a miracle in the sense that the learning has become so fast, the implementation has become rapid, moving from a consumption healthcare economy to a production-based health economy, using initiatives that allows you to access data. Then you can actually microscopically go down and do remote patient monitoring at disease level. And you know that these chronic disease management initiatives, they focus on the asthma, obesity, and it's very important to actually guard the initiatives with the amount of data that you can utilize to build decision support mechanisms and move from data science into decision science. And the UAE, from the different initiatives that we have, the hyper digitalization, hyper legislation, with great leaders and talents, and shepherded by the vision of the great leadership of the UAE as well.
Thank you. So, Dr. Khulud, would you like to add to this?
Yeah, I mean, definitely telehealth changed the way we perceive healthcare, and even as patients, the way we receive healthcare. Even as healthcare providers and health regulators on how we regulate healthcare has changed definitely. I would like to visualize the healthcare now as a pyramid, if you can visualize that with me at the moment. A big pyramid in the UAE is how we see healthcare. The bottom of the pyramid, which is the biggest part of it, is the chronic diseases in the UAE. We have diabetes and obesity very common in the UAE, and it takes the bulk of the healthcare resources. And then at the very top is where the preventive measures are taking place. Now, what I would like to say telehealth did, it reversed that pyramid upside down. So the biggest bulk of the pyramid is primary care and wellness. And this is where the key of telehealth is. We are preventing care, we are educating patients, we are providing primary care and consultations online. This is where the success of telehealth is taking place, and the bulk of the service is taking place in order to prevent diseases or progression of the diseases.
Yeah. And you mentioned, you touched upon the chronic diseases as well. Would you like to add to this?
Yeah, I agree. This is the technology actually enables the shift from reactive to proactive healthcare. This is the most important. We should use the technology for that. I'm happy you take the example of Asthma 2, because Asthma 2 is integrated in our platform for remote patient monitoring, and your son is using our platform. It means that you get the information from the patient every single day, And suddenly, middle of the treatment, the doctor has access to the data, can change the treatment if it's not working. So we have done studies. One of our customers is the region Jämtland Härjedal, and they did their own study, 50% less hospital admission for heart failure. So you can imagine how much is it the cost for the healthcare reducing, because the patient retroactively can take the action before is something happening. We are talking about, for instance, asthma, diabetes, lung diseases. So the list is long, and if we are taking the action in the right, one thing is very important. When we're discussing with the different region stakeholders in Sweden, they are very afraid that to create a new process in the healthcare. But this is not the problem. The problem is the mindset of the caregiver, how we can integrate it, the technology, in the existing process. So this is not the new way of the working, but the new way of the using the technology. Otherwise, it's waste of time and money for everybody.
So how can we make that shift happen? How can we, because most of you are talking about access to care and patient empowerment and patient involvement. So how do we make this change, this transition? How do we make it happen? Who wants to go first? Dr. Khalou?
Yes, we had this challenge in Dubai, obviously, to accept the new technology and how to adapt. They were always wondering, who's that person behind the screen? Is it an AI? Is it a real person behind that screen who would be giving me a consultation? How can I get my medication without being seen or physically examined? So I think the best way around this is to generate engagement, first of all, with the patient. Give that wow factor that you will be having that concierge service, that personalized care at home, and at the same time make it very simple. I mean, there's a reason why WhatsApp works, right? Because it's simple. We want to have a very simple platform so that patients can use it easier, and that's one way of generating engagement. The second way is by motivating change for the patient. How do you motivate change? Is by inducing thrill and not fear. For example, I can say, smoking can cause cancer, and the answer would be like, there's no one in the family that has cancer, or I'd be too old by the time I get cancer. But then when I induce a positive enforcement, like for example in our case, Sheikh Mohammed bin Rashid, he initiated the first call on the telehealth, and people wanted that sense of belonging, that I want to be part of that. I want to be like everyone else, getting that benefit, trying this out, and immediately giving a positive reward after that. We all want to see smiling faces. We all want to see a star or a tick that yes, it's working. My HbA1c is now lower. That's a diabetic indicator is coming lower, which means I'm improving. And then this is how I progress the monitoring. And finally, I think another important thing is to empower patients. The more they know, the more they're going to help. And one example I'd like to think of in the States is the app, I think it's called Stop Initiative, where if there's bleeding, they use 2 fingers to stop. And they teach the population how to use it, and this would save life. And it's a very simple procedure. And this might be a bit extreme in our case here at the UAE, but the more they know, the more we involve them, and they learn how they do things on a simple device, the more they'll be involved and interested to do so.
Dr. Farokhneh, I know you're also a big fan of patient engagement and patient empowerment.
Yeah, of course. So much is already said very wisely. I just want to emphasize, yeah, you're so right about engaging the users, and the patient experience is very important in that case. And one example was, yeah, my son. I mean, it wasn't that hard to kind of encourage him to continue using that device, because it helps him to understand being empowered, to feel good, to be able to play with his friends and avoid going to the hospital. And I just want to add another thing, and I mean, back to the first one, engaging the users. There's been and still is a pandemic around the world. And many people, I mean, we needed to just shut the physical units to avoid having that virus to get spread. So the shift towards remote consultations was quite fast. So that's one thing, using a crisis to push the kind of shift. So that's one thing. But, you know, one challenge is, as you know, I mean, all of us sitting here, we are obviously early adopters or people who wants to work more kind of specific with innovations. But there are also a lot of colleagues out there. They don't get it 100%. And I think it's because we are all educated in a 100% traditional or physical context. So every colleague hasn't understand or been using all these gadgets. And one question I often get is, oh, what am I supposed to do with all this data? You know, they kind of think that there are a lot of data just coming towards them without having any tools to handle the data. So we need to educate and tell people or our physicians, and then do more of collaborations in between engineers and doctors to see how we can help each other with different competences to be able to be a part of this transformation.
Yeah, thank you. And Dr. Gadir?
Yes, I think that's a fantastic opening door for, you're opening the door for, when you talk about patient engagement, comes in new opportunities. Okay, with patient engagement, you can opening the door for new opportunities, and these new opportunities are data rich. For sure, data rich in the sense that first of all, you gotta pull your thoughts together and start thinking about data governance. And that's one of the big initiatives that has come up in the UAE, the healthcare ICT data law, which again helps us get more closer to a much more patient engagement driven model. Obviously, the community activities that was mentioned by Dr. Khulud are again a good example that healthcare is about the community activity, the positiveness of human-to-human interaction, which actually led by driven by the leadership to install the community principles of driving positive and basically behavioral change. And that always goes in line with the value-based care transformation that has been happening for some time, and we are driving all our activities, all our digitization, all our legislation towards that. And I think patient engagement is a door opener for innovation, definitely, for hyper legislation and looking at new governance models when it comes to data governance, when it comes to look at privacy and confidentiality. Not only that, but also you're disrupting the actual skill set. So the workforce, the development, and the skilling up of the workforce of the future, as Dr. Khulud said, and my colleagues on the panel said. Now you're talking about remote care. So what sort of skill set do you need? Our clinicians, who are also borderline burned out, by the way. The clinicians are going through a huge, massive transformation and pressure, being not only medically experts, but digitally savvy economists, technology enthusiasts, emotional, like say psychiatrists and psychologists, because they have to have that human-to-human interaction with the patient. So the burden on the clinicians, and God bless them, my love and my appreciation goes to the champions, including the patients who are also in the front line. So again, the patient engagement is a wonderful umbrella that opens the door for value-based care.
Thank you. Anders, you're going to actually have the final word here, because we need to wrap up this panel. I'm sure we could continue this for hours, but we have a very interesting program to go ahead with. Anders, I'm going to give you a final word.
Yeah, thank you. And just a comment there, and we talked about COVID here as well, and I think we have been working for years that we promote a system as telehealth, remote care. The fact was that 70% of all our users around the world used it in the clinic. When they came in the clinic, they wanted to talk to the physician in the clinic, but we always marketed it as a remote care. When COVID came, early 2020 or March, April, when we had the lockdowns, we had a decline of 95% of all activities for a couple of weeks. After that, it took off again. But then we had the remote care in real life, or for real. So now we are on 70, 80% coming from home with the care model. Before COVID, it was 80% in clinic. So now we think it's a quite stable line here, that it's now it's remote care and telehealth for real, and we could help the clinicians to sort out the patients that need the most care and helping them in that way. So I think it's that was the thing that happened with COVID, that we could really work with healthcare in remote care.
Thank you. And thank you everyone in the panel. It's been a very interesting discussion. And I think now we should move on to our next panel, which is panel number 2. Thank you. So for our next panel, we have a digital keynote speaker to start us off. It's Professor Per-Ola Karlsson, who is joining us from Uppsala University Hospital, where he is a professor and a senior consultant in endocrinology. I hope we have him online.
Yes, thank you for this kind introduction. Hope everyone can hear me. I will give a short introduction to the subject. Could I please have slides presented? Thank you. Well, we will discuss what does it take to be a front runner in health data. And next slide, please. Machine learning using artificial intelligence could be a solution to big data problems in healthcare. We have an increasing amount of continuous health data, and those are generated in many different fields. We have continuous ECG, electrocardiography measurements, EEG measurements. We have, not the least, what I have been working with a lot, continuous glucose monitoring data. And we also, of course, have radiology, where we use computed tomography, MRI, which causes a lot of digital sections. And for the individual clinician, it is extremely difficult to go through all data. Instead, they scan a section, a couple of sections in each MRI scan, and hope that not a very small detail is missed in the middle. So we need to be careful, and perhaps machine learning techniques could be used to solve these issues. Next slide, please. For the continuous glucose monitoring data, we know that formerly they measured blood glucose, and then they perhaps measured at best 5 times a day their blood glucose. But nowadays we have continuous measurements scanning 5 to 15 minutes interval with interstitial glucose levels, and that means when they come to the doctor or the nurse after half a year sometimes, we have 40,000 data points that needs to be taken into account, and of course we do not have a capacity to do that. Instead we look at the last 14 days. Next slide, please. This introduction of CGM has been extremely popular among the patients, the individuals with diabetes, and they feel that now they have control over their blood glucose. They know what the blood glucose is, and it is very easy to check. But on the other hand, they have not much improved their blood glucose control. They know the blood glucose, but they don't have the instruments actually to cope with it, to change their blood glucose control. And as a professional help, we could perhaps do that, but then we don't have a power, because we don't have a capacity to meet them more on a very short basis. So it could also be that we would need to supply them with technique to interpret the data. Next slide, please. We have used, for example, in a collaboration, machine learning models to investigate the reasons for why the patients encounter hypoglycemia, and use different learning models to see if it is due to their basal insulin dose, if it's due to high bolus doses of insulin, or a high compensation of hyperglycemia. And if we can tell the patients why they have swings of blood glucose, perhaps they could diminish these swings. Next slide, please. And this is a presentation of, for example, of our clinic of the different reasons for hypoglycemic events and the root causes based on this type of machine learning technique. And for example, the one to the left mainly has problems with too high basal insulin pressure, and that is quite easily changed. You can recommend them to decrease your basal insulin dose taken once daily, and then reasonably she will have less hypoglycemic events. Next slide, please. So this could be something which could be really of importance for the patients, and to help them and use digital remote care. Next slide, please. So this is a way of handling lifestyle-related disease, prevention, early detection, and behavioral change. Next slide, please. Next slide, please. So I think this is in the next presentation. I don't recognize the slides. Sorry about that. That's been composed by someone else.
We have someone else in the audience who knows the slides very well.
I will just conclude that in this manner we could supply the patients with an application actually in their mobile phone, so that they get feedback to them on what is wrong with their insulin dosing, what causes the hypoglycemic events, and then they can use this change, and then we can do a new analysis remote on the CGM curves and present the results and recommendations in an app. So this is a way to help the patients, and diabetes is a very special disease because a lot of changes and insulin dosing is changed by the patients themselves and not by the healthcare. So it is truly a disease where it is focused mainly on the patient. Thank you.
Thank you. Thank you. So let's move on to the panel then. And I'd like to welcome back to the stage Professor Marcus Lingman. And also welcome up to the stage Andrew Wilson, who is a President Oncology Informatics Solutions at Elekta. Please, you can take these two seats. And on link we have, of course, Professor Per-Ola Karlsson, and also Maria Bäcklund Hassel, who is an international coordinator for the Swedish eHealth Agency. Welcome.
Thank you.
So let's get started. For the first question, I would like to ask you, what is, when it comes to access to health data, what is your biggest concern right now? Maybe we should do ladies first. Maria.
Thank you. Yeah, my biggest concern is connected to actually what's the biggest advantage we have in Sweden, and that is the trust the citizens put in us. Swedes have great trust for the government agencies, for healthcare institutions. They trust us to use and handle their information with care and respectfully, in a respectful way. So my greatest concern is that we somehow jeopardize that trust.
Yeah, Mr. Wilson, what do you think?
I think it's an area that's been touched many times today, and that is the definition of borders. Mm-hmm. Data control and access across borders for information, for data, because before we really created borders, I mean, people were living, I mean, I'm talking thousands of years ago, people were living together in their own villages, and diseases and cultures and a lot of genetic information was all circularized around that aspect. But as we've gone broad today, I mean, we have a very intermingled society, but we're still limited within where you live and what health system that you're part of, or what governing law you're under as to whether or not your data is accessible or permissible to be able to be moved. And I think being able to control that, the answer to that, is probably a large opening step as to getting a more globalized real-world evidence platform for everybody.
Professor Lingman, what do you say?
I think we could approach this question from two angles. Access to data from the patient angle. The patient, him or herself, needs access to information based on data in order to be involved in the care taken. But also the provider needs to have the appropriate access to data. On the individual level, the clinician-patient relation, but also on the provider system level, so that you can guarantee that the quality of care is good enough. And what we see as challenges today is actually this joining the skills using the data. Those could be either experts or patients who are experts at their own disease, and the data itself. And there are a number of locking in ways of locking in the data from these experts, and the joining of experts and data is something that we really need to understand better to progress and go forward in this situation. And the locking in, the ways of locking in data are several, on several layers. There are certainly regulatory layers, but there are also technical layers that you cannot combine the glucose data with the outcome data for the patient, for example. We need to know how well the patient fares in relation to the profile of the glucose data collected. And that is not readily done today. And also there are cultural ways of locking in the data and keeping it away from those who need to use it. So there are regulatory, technical, cultural, and sometimes lack of incentives to actually use the data in the way it could be. And you need to address all those layers in order to translate the data into value by embracing the patient engagement, and also for secondary uses of data like research and care delivery planning.
Mm-hmm. Thank you. Per-Ola, what's your biggest concern right now?
It is, of course, the digitalization of healthcare means that we have a lot of health data, and it is, of course, an integrity issue to have this, because we also need to share it with companies. We need to share it with the subjects with diseases and so on. So there is always a risk that someone could steal data, and that is the main problem actually, because otherwise it's an ideal situation actually that we can share data between us. One thing that I think is a necessity, but it still hinders some development, is that we can use data and we can transfer data after anonymization to companies, but for these kind of development of new machine learning techniques, perhaps we need some more information on the subject himself with regard to other diseases and so on, to fully use and interpret the data. There it becomes an integrity issue, and that is perhaps a problem. So we need to define what kind of data that can be shared to help out with these kind of machine learning technique developments.
Yeah. Thank you. When we talk about health data, I think that one of the issues is that sometimes it gets so so big, and it gets quite far away from the patient and the actual patient impact. So maybe if we could talk about some concrete patient impacts on increased access and utilization of health data. Like how will increased access of health data actually improve the patient care and outcomes for patients? Mr. Wilson, would you like to start?
Well, we're already seeing it in some of our applications in oncology care, specifically around survivorship and in using the technology, being able to provide better risk stratification, which is what we heard this morning, of being able to say to patients, during this treatment, there will be some form of adverse outcomes that you'll have, but we can educate you before they happen. And that in itself has meant that patients, they want to be engaged in their healthcare treatment. They want to understand what's going on. The families want to be involved. So it's a broader group of people looking. But we've already seen in survivorship of cancer patients, by using patient engagement tools and access to data, already increases in survivorship and better outcomes. I mean, in some studies we've seen up to 5 to 6 months of prolonged longevity, which is really quite significant. At a cost, it's a very low cost compared to the pharmaceutical industry that would have to spend billions just to gain that level of increased survivorship. So the technology is already saying to us from an outcomes perspective, we're already there to be able to see it. I think the opportunity that it's really going to generate to us is, as we now start to put predictive measurements into the technology at the start, hopefully we can even shift the curve earlier and remove early diagnosis and early detection to more prevention. If prevention is the ultimate goal from our perspective.
Thank you. So interesting coming back to the patient engagement from the last panel, and if we want to talk concrete patient impact, I think surviving is a very, very concrete patient impact.
It's one everyone's concerned about.
Yeah, it is. Maria, would you like to comment on that?
No, I think it's very interesting, and one source of information, source of healthcare data we have in Sweden is our national quality registries, which I think are like an untapped gold mine. They have been, some of them have been in use for more than 50 years now, and they're brilliant. More than hundreds of them. There's so much information in there, and they are used for improving the quality of care and sort of better certain procedures and so forth, improved procedures and so forth, and follow up. But I think they could be used in a much more in a much bigger way, I'd say, combined with other information, obviously. But there has to be done some work on them, I think, because they are so many, and they've sort of grown organically from the clinicians' need, over time. So that would be that's an untapped resource in Sweden, I think.
I also think that the journal systems that we use in the healthcare could be used to evaluate real-world data on the outcome, which kind of medicines that are most effective to treat the condition, and perhaps more into a personalized medicine, what aspects in a patient, what kind of patients respond to a certain medication. If we have a possibility to analyze in a simple way data from the journal systems, we could draw such conclusions, and perhaps those kind of data are not available in these national registries, but could be developed out of the systems. And there are some journal systems that are quite common in Sweden that try to develop these kind of analytical responses, and I think that could be a very good way to help us know which kind of medicines that should be used in each patient.
If I just can add something there, we're in the process, most regions in Sweden are in the process of switching systems to a much more modern system, because this is the sort of drawback of being digitalized quite early. The first systems weren't really built with the, what should I say, interoperability was not a word that was used a lot in those days. But these days we do know how to use, how we could use the information that is stored in the systems. So yeah, you're right. It could be, it just could get better.
So how far have we come along? We've talked about interoperability for quite some time now. How far have we come along in that area? What do you say?
We're making progress. There are data standards coming up now, being more and more used by different providers, and that is clearly needed to achieve that value for the individual patient that you were referring to. To me, that is using data on the individual level is all about getting a fact-based, holistic view of your health situation in order to reach a tailored treatment for you as an individual and not as part of a group of individuals with the same type of cancer. Mm-hmm. And when you do that, you achieve longer lives. We have proof of that across the sector. Tailoring care for you and also making it more preventive or predicting. And in cancer care, there are an array of examples now where diseases are turned from deadly diseases into chronic diseases, where you live with your cancer at a lifespan that is normalized, even though you carry a deadly disease, potentially deadly disease within you. So the impact of using holistic data for you as an individual is super clear and super cost efficient, because it rarely requires grand investments on the level of new fancy pharmaceuticals and others. It's just understanding the situation better for you, your cancer, your comorbidity, your lifestyle, etc.
Thank you. So I want to talk a little bit about international collaborations. How important are they? Unfortunately, Dr. El Hassan from the Dubai Health Authority had to cancel last minute. He was supposed to join the panel. So it's a quite Swedish-European panel that we have here on stage. But still, let's talk a little bit about the European or the international collaborations. How important are they for using health data? Who wants to go first?
Critically important. On many different levels as well too. I was talking earlier around the impact of borders and different regulations and cultures and ethics that drive policy, but we're a global world now, and if we want to understand a lot of the omics that Dr. Lingman was saying earlier today that we're learning a lot more about, people are all around the world. People that go right back to early civilizations are not just living where they are, they're living elsewhere. So these kind of collaborations will allow us to be able to learn more from an individual level rather than a group level as well, because each group in some country is no longer that these are all people in this area that are Arabic. There could be many people that are from the south of Africa or the west of Africa. There are many people from Western Asia and even Southeast Asia as well in this society within this boundary. So being able to align the information that exists from those other regions with this information right down at the patient's biological level will allow us to learn a lot more about the environmental impacts in terms of individualization, because we know patients will get we're learning in terms of how to diagnose and how to predict and prevent based on the patient information. But if they've had a disease and then they go back home, what is the contribution of the environmental information that has an impact on their survivorship and longevity? And then also the cause of that in the first sense. So my point is saying that we're no longer just the same people in the same spots anymore. We're actually very global, and we should utilize that ability across different institutions to be able to learn the subsets of the patient information in there.
Professor Cousin, what do you say?
I would say that we would also personalize medicine more fine-tuned by having much larger databases that are created in an international fashion, and perhaps not only environmental aspects but also genetic aspects, because we know that there are a lot of genes that couple to diseases, but it is perhaps not so that, for example, one gene that increases the susceptibility for type 2 diabetes should have the same medication as one another.
Thank you. And Maria, I know that you moved from data lakes to data space. Is that right?
Yes, we've gone to space. Well, that's a priority from the European Commission, the European Health Data Space, that would achieve that, to have a bigger base of information if we can pull together the information from all our European countries. It's a start anyway. It's not all around the world yet, but we start with the European Health Data Space. And we also have something similar on a Nordic level, something called the Nordic Commons, which is a vision that we could share health data within the Nordic countries. But we're quite similar in the sense that we've gathered information for a long time. We in Sweden have done that through our national quality registries, and the other countries have done something similar. So yeah, it is a very interesting area. And there's also I'm probably not saying this right, but the 1 Million Genome Project that we are participating in Sweden. And another project we're doing together with the other 24 other member states in Europe is actually the joint action towards the health data space, because it's easy to say we have a vision of an e-health, of a European health data space. We also have to know how to get there. So what are why can't we get there? What's the legal challenges? What's the sort of existing governance that we can draw good examples from, and so forth. So it is exciting, and I think it's exciting that there is a political will all over Europe to achieve this. Sorry.
And expanding on that, the very last question, it's a question for all of you. Where will we be in either 5 or 10 years, depending on how big you want to dream? Maria, you can go first.
No, I would very much like to see the European Health Data Space be sort of the pilot study of world health data space. Can we imagine that?
It sounds good to me. Professor Karlsson, what do you say? Where will we be in 5 or 10 years? Did we lose the link, perhaps? Let's go with the panelists here. What do you say? Where will we be in 5 or 10 years?
We have data standards making us able to collaborate across borders. We have increased networks, making progress in these sometimes difficult and challenging venues requires very specific skills, and sometimes one skill is in one country and the data is in another, and the third skill is in a third country. And once you gather these specialists with the data across borders, then that's where the magic happens. And I would say no single country today has all the skills that would be required to reach the very high space that we would like to reach. But once you succeed, magic really does happen, and I've seen it, and it's a cool place to be.
I like that.
That's very good, very good. Well, if I think about cancer, because that's the area that we work in very specifically, I think there's an opportunity once we learn and learn and learn, maybe to rewrite the definitions of what we all are, because medicine defines you. Medicine is ageist, it's sexist, it's you know, you're this nationality and you're this age and you're this, and that's how we break everything down. So the social construct of what everybody is moving to is to try to move away from those barriers, but medicine is still defined right in that space. An example of that is women have mammography when they're 40 years old as part of a screening program. Pretty much generally accepted in the countries that can support that, to provide that as the screening mandate. But, okay, maybe it's a little bit obvious why women, but certainly why 40? Why the age of 40? And the fact that there are many women who are actually being positively diagnosed in those screening programs, we kind of think it's successful, but isn't that a little bit of a failure in some way? Because everyone who turns 40 is a little bit different. 40 is just a time definition of how long you've been on the planet, not exactly what your body has come to. So I'd like really to see the opportunity through through what we've done, whether it's 5 years or 10 years, to be able to define more predictive and preventative programs and screening based around the information rather than based around the definition of rules that have existed for many years.
Thank you.
Mm-hmm.
I could comment. I think that we have now collected an extreme amount of data, and we continuously do that, but we have not developed so much strategies to use the data and run it together from different countries, from even different hospitals. So that is a necessity, I think, within the next 5 to 10 years to establish. And if we have that, then we can do a lot of things with these data over the years.
Thank you. I think that's perfect closing words for this panel. Thank you, everyone, for joining.
Thank you.
So now it's time for the third and final panel on handling lifestyle-related diseases, prevention, early detection, and behavioral change. So our keynote for this panel is a pediatrician, a highly published researcher, professor at Karolinska Institutet, and the head of the Swedish National Childhood Obesity Register. Welcome, Claude Marcus.
Thank you very much for inviting me here. Thank you, Business Sweden, because I think this is a very important and very exciting meeting. So, handling lifestyle-related diseases, prevention, early detection, and behavioral change. If we start with the first important word is prevention. That is something that we discuss quite a lot, but we are quite bad at that, I would say. If you take childhood obesity, for example, we know that it's important to treat it and to prevent it. We know that childhood obesity is causing lots of diseases later on, and we know that obesity is due to that we have many lifestyle factors that we can really treat. I don't think everybody is aware of that there are many diseases associated with inflammation, and that occurs early in childhood obesity. I don't think everybody knows that cognition defects, multiple sclerosis, cancers, inflammatory bowel disease, and asthma are partly due to childhood obesity. And when we know that, we also realize that we need to prevent and treat childhood obesity very early in life, already before 10 years of life, if you want really to prevent these diseases. If you want to do that, the behavioral change is the key. And how do we do this? Well, the foundation has been for a very long time that if you want to teach individuals, if you teach them, and if they understand why it is important, then everything will be good. If they really understand why and how, then we can prevent things. But is this really true? I would say that this, to some extent, is fake news. I really think so. And we know, for example, from smoking, we know that I think every child knows that that smoking is killing you. But that does not prevent everybody from smoking, as we well know. So I think this is very important to realize that the behavioral change education efforts, they are effective as long as they continue. But when you stop, they are not effective any longer. And that is a message in there. And that means that the effectiveness is so short-lived, so you need to combine this with something else. Education is, of course, important, but it is insufficient. You need to have a long-time support to prevent diseases. And this continuous long-time support is very expensive and time-consuming, and not that fun for the healthcare to work with, to be honest. And I think this is where the digital tools come in. Because with digital support, you can do so much more, and you can do it much more effectively, and you can provide continuous support that you need to have to be successful with long-time prevention. I think I'll stop this because this is not mine. Okay, thank you very much.
Thank you. So let's invite the rest of the panel up. We have Dr. Asma Deb, who's a chairwoman of pediatric endocrinology at Sheikh Shaboot Medical City, Abu Dhabi. Welcome.
Thank you.
And Marie Öberg Lindevall, who's a chairwoman for Digital Diabetes Analytics. Welcome. And of course, Professor Claude Marcus, who we already know. And joining us on link, we have Francesco Mazzotta, who is CEO and co-founder of Piloxa. Hello.
Hi, nice meeting you.
So let's get started. So when we're talking about this area, the lifestyle-related diseases and prevention and early detection and behavioral change, so it's a very broad area. And I'm going to start with a broad question. What is your vision when it comes to this area?
Right. First of all, I would like to thank you sincerely for inviting me, and to you, Mr. Buki, for the hospitality. Thank you very much indeed. This area is really very dear to my heart, and talking about lifestyle-related diseases, it's quite relevant. I'm really delighted you've chose that. If you look at data from United Arab Emirates, where I lived for quite a while now, you will realize that 75% of deaths in United Arab Emirates is related to non-communicable diseases and lifestyle-related illnesses. And if we talk specifically about behavior, I'd like to raise one important example that shows how this strongly is evidence-based. And very briefly, I'll tell you about a study we have undertaken looking at this very point. Everybody talks about education when it comes to childhood obesity. And we went down in the field and interviewed 500 children with obesity and with normal weight children. And we asked them questions, and we gave them quizzes about what healthy lifestyle means. And it was really impressive because even children with obesity knew everything. So they scored exactly the same as other children with no obesity. They knew that the apple is better than a cookie when it comes to healthy, yet they will still eat the cookie when time comes for snacks. So what I'm trying to say is behavior is definitely important. I'm not trying to underestimate the education here. It's critically important. But again, we need to apply the education and incorporate behavior. We have published this data in one of the medical journals, and by that piece of evidence-based, I managed to persuade our CMO to employ a psychologist. And then, when things started to work, we now have 3 psychologists. So to sum up the answer to your very important question, behavior is critically important, and education alone is never sufficient. Thank you.
Thank you. Claude Marcus, would you like to join in?
Well, I couldn't agree more, as you understand. But this is what is so difficult, because we are academics, and we think that it's enough with teaching, and it's not. You need this continuous support, and my vision is that we will be able to use modern technique to provide that to many people.
Yeah. Thank you. So, Marie?
Well, I couldn't agree more. And I come from the more practical, side, and as a supplier or a developer. And what we have done is that we have developed. To start, we have to say that everything. I think we have come to a point. If we also compare to what we have discussed earlier today, we all have the knowledge. We all have the knowledge today, but it's still. the working methods and the way the healthcare applies it is still very backward, because we don't take into account, we don't use all the technique and the knowledge as we have on the system level. And that means when it comes down to each individual, and both as a patient or a person, and then to the individuals as a physician or a nurse or a person working within healthcare, it comes to that unique meeting. And if we don't have, or we don't use the technique on a system level or dare to apply the technique, we still work as we did 30, 40, 50 years ago. We have the knowledge, but still it's very individual, and we don't use the technique. So what we have done within the company, as I'm the chairwoman of, is that we have taken the technique. All the persons in the Western world at least have the CGM, as Per-Ola was talking about, the CGM sensors. People with type 1 diabetes, they have a small button on the arm or on the stomach, where they continuously monitor their diabetes today. And they know, the persons with diabetes type 1, they know more about their own disease and the chronic disease than their physicians or dietist or the nurse. But still, and they have all the data, and they treat themselves every day with the insulin. But the care, the healthcare, they don't use the data, because they can't, because it's too many measurements, it's too much data, as Per-Ola said. And that's why then we need to, what we have done then is we have taken all those data and we have trained it on thousands of pages in Uppsala, and then we have developed an algorithm which automatically analyze the data from those CGMs. And as Per-Ola said when we started to develop this, was that this is much better than all our the professionals as a nice university hospital in Uppsala or Karolinska. So why don't we? So that's why he got keen on it and started to work with us within this company. But still, when we are now trying to sell it to the healthcare providers, there is a fear what happens if we use it. Even if this product is CE marked and have all the regulatory things done, there is still a fear to use it, because what can happen. And I think there is, you can't treat all the healthcare data in the same manner. I think you have to make some risk assessments, which data is a big risk that it can be shared to a lot of persons. So that's my take on this.
Francisco, I see you're almost jumping in your seat. Do you want to chime in?
Actually, I'm standing. Give you a bit more energy also to me. So I come from tech background. My 2 cents are there are already like companies driving behavioral change, and they are working in the social media area. I would push for a healthcare to be at the same level and in 5 to 10 years. And the way I see we're doing it is by opening up healthcare to people with different backgrounds and hiring people with different backgrounds into healthcare and drive that knowledge in, so that we can together build something greater. How we do that, I think just removing the silos and make sure that all the talent working for driving behavioral change in other tools, it could be a financial tools, it could be social media tools, understand that there is a lot of impact that can be done in healthcare, that we want to have them with us driving positive impact for society and individual, and that it's an extremely rewarding environment to work with.
Thank you. So if we want to establish this change from sick care to health care, what do we need to do? How can we change the healthcare system? We know that healthcare is not maybe the most easily changed industry. How can we change this, and who will change? Will it be the doctors or the patients or the companies? Who's responsible for this? Who will drive the change? Will you do it?
Yeah, I think first of all, we need to realize that the healthcare is extremely conservative. We think that we are open-minded, but to tell the truth, we are not. It's very difficult to change views in this world. And of course, it's good from one perspective because you want to save life. So you don't want to change things without being very sure that it is good to do it. The other reason why it's complicated to do this is because everybody who is working in this sector wants to save lives. That's why we are here. And it's easy to see that the things you are doing are effective when you see the effect within days or at least years. But prevention is something totally different. Prevention, then you will save lives in decades. And then you need a different mindset to do this. And I think that will take time as well, because it is time-consuming and it is an extra burden, and it's not what drives you, really. And again, I think if we have other tools, I think we can, as doctors, really be drivers in this. But then we need simple tools that we can use, so it won't take too much of our time, to be honest.
Yeah. So but you talked about when you have a tool, a CE-marked tool, even then there is some resistance.
Yeah, and that's why I think, if you're talking about the chronic diseases, then the persons who have it, they know a lot more about themselves. And then also I think that the healthcare system, they must allow those persons to try new things and use it. And then the doctors, of course, as you say, are always a bit, you can always stay behind and say we are here to save lives, and in the daily life you just want to have. You want as all persons at your work. You don't want to work with things which are boring. And so I think that the new technology is here, and that is also then to show for, to get the physicians and the people, nurses, etc., at the hospitals or healthcare systems or providers, that it helps them in their daily work, so that you can take away the boring work. Because if you take diabetes, for example, it's not so fun now if you take for the type 1 diabetes specialist or the nurses there. It's not fun for a doctor to sit with the patient 45 minutes and look at the curves on the paper and try to. Because if you come you come there once a year or twice a year, and you don't get the time to talk to the patient with the things that you want to do, because now you have the technology, you have the curves from the sensors. But if you then let a machine or an algorithm do the boring job, then you can, you don't have to meet and see that patient 45 minutes, because you know today that you don't need it, but you have that in, now I'm talking about Sweden. It's 45 minutes for the patient visits, and in Europe it's about 10 minutes. So what we see there as a supplier of new technology, the doctors in the Western Europe, they say, wow, this can help me to get home and give my kids food during the night, because I get the time to do the right things for my patients. So I think this is also one of, it's from the supplier side, a lot of suppliers or develop a new technology, they don't have the knowledge of how a doctor, a physician, or a nurse think, and how to change their attitudes and behavior. And I think this is crucial. So that the technology is there, and you can use the technology from a lot of sectors like the gaming industry, etc. But the gaming industry and the AI and industry, they don't know how to reach the senior physician, how to use the technology. I think that is the key. And then, of course, the patients and the persons, just give them the tools, and then it's nobody. There is also fear from the hospitals and and the people working there, that all persons want to go to healthcare provider, but it's none who want to go to healthcare provider. If you don't have to, you don't go there. And especially the persons with chronic diseases, you have a very old system how you work now. It's steered from. You shall come here two or once one time a year or twice. But if you are well treated, you don't have to go there every year. You can come there 3 times a year or just chat with the doctor and get the recipe as you need. You don't have to come there. You don't want to go there. So I think this culture change, which has to happen, and of course it's not easy.
Do you agree, Dr. Asma? Do you think is there a cultural difference here, or do you experience the same?
Yeah, I think I'm really glad you asked this question. Who is supposed to make the change? And generally speaking, the answer to that should be, at least in my humble opinion, everybody. Because if we're talking about changing the healthcare system, then we cannot exclude any of the stakeholders, starting by patient, family, policymakers, decision-making, insurers, industry, as well as government. So specifically talking about childhood obesity, I think a key factor for involvement in changing management is family, for example. 2 reasons why I'm saying this. The first reason is, and especially because you touched and asked on culture. In the UAE, where I lived quite a significant number of years here, the culture and the perception is different. The culture or the way parents perceive obesity is different. In one of the studies that my colleague Abdallah Jnebi has undertaken, he interviewed parents. And these parents had children who are either of normal weight, underweight, or obese. And it's very interesting, the results that he showed, because in the group of children with obesity, only 20% of parents acknowledged that their children are obese. They just consider them as normal. While when we apply the scientific definitions that we've just heard, all these children are obese, yet their parents do not see them obese. And this is a problem because that's the start. Recognition of the problem is hugely important, hence involving family. And the other reason why I think involving family in management of childhood obesity in general is important is because of the strong family history of obesity in these children. And it's not only that we see hundreds, if not thousands, of children with obesity in clinic. And it's not surprising when these children come with their parents who are obese too. And if they are not obese, the parents, you see the huge spectrum of diseases related to obesity in the parents. So it's not unusual for that child, when we take history, that adolescent will say, oh yes, my mother has diabetes, my father has dyslipidemia, my uncle died of coronary heart disease. So what I'm trying to say is changing the health care. If we are specifically talking about childhood obesity, we need to make it family-centered. There's no way things will work if we treat the adolescent individually. It has to be, children live in families. And if we do not educate, empower, and impose behavioral change, and educate on the perception of disease, we need to reach a stage where we all recognize obesity as a disease, because that's a start. It's not just that children have a different figure. And very briefly, in less than a minute, I will finish the answer to this question by one other study that I have heard about in one of platform like this, talking obesity, is people were surveyed about self-esteem and health perception, and they were given 4 categories of adolescents with chronic diseases. One was type 1 diabetes. The other one was morbid obesity. The third one was rheumatoid arthritis. And the final group was children with cancer on active chemotherapy. And all these children were tested about their impression of quality of life. And to my great surprise, children with morbid obesity scored highest. They had the worst health perception and the quality of life. So this is incredibly important. Back to behavior and the health theme, changing healthcare. Thank you.
So Francisco, I know you're are you back? I think the screen is frozen again.
Oh, no.
No? Okay, good. I know that childhood obesity is now your area of expertise, but coming back to who is responsible for the changes that we need to make in healthcare, what's your take on that?
So, can you hear me at least?
Yes, we don't see you, but we hear you.
Oh, that's perfect. But then at least you can hear me. It's a really important question. I think it's a democratic question. It's going to be a very important question. If you don't do anything now, we will create the largest inequality in society in the next 30 years than what we had before we established healthcare as it is today. And the reason behind it is that right now there are more and more tools to be more and more healthy, and there will be more coming out on the market. And the problem is that I'm doing healthcare, I like myself. So I'm interested. I'm paying for services. I'm trying to drive that evolution forward for my personal body. So I think that the problem is that right now we create a divide. If we don't succeed in this, we create a divide between people according to wealth, interest, and education and environment, like we were speaking about. So my suggestion behind it is that it's a complex problem with roots in society, in cultural, and there is a lot of opportunities out there. What I would suggest is to open up innovation and make sure we finance small-scale tests that drive different ways, fundamentally different ways to drive healthcare, and see what works where and how. Like our healthcare system was built like centuries ago, where there was a short lifespan and the diseases were coming and then killing you not so long in the future. Then we piled up diagnosis, we piled up things, and now it's blooming up into a scale that makes it, I think, to the brink of efficiency regarding healthcare more than sick care. So I would really like to have new opportunities, new ways from scratch to test concepts and see what we can learn from it. So do more at small scales, learn more, and make sure we bridge the gap before we split society.
Thank you. And that will be the final words for this panel. Thank you very much for joining us.
Thank you.
Thank you.
And now we are moving on to the final segment where we have some Swedish companies that will do short presentations of their solutions. And first off, we will welcome up Masoud Jadidi from Imagine Care back on the stage.
Thank you very much. Do you hear me? Very good. Actually, I'm not going to talk about our product. I believe it's very important to understand why and how. What we are doing is something else that I can stay after presentation and we can discuss how much we want. So what you are going to see here is a very short video, less than 4 minutes, about one of our customers. You are going to see the 3 angles of the solution of remote patient monitoring. And remote patient monitoring, this is what we are focusing on Imaging Care. So in Sweden, we have 2 regions. When we are talking about the regions, is included the healthcare system in that region. We are talking about the primary care, secondary care, hospitals, specialist care, and so on and so on. So closing the bridge between different sectors. This is what we are talking today. So the region we are looking for, the CEO of the region is going to talk about it, a nurse of the personal staff is going to talk about it, and the patient. So we are going to listen in different pains, how we solve the pains. Yeah? And this region called for Jämtland Härjedalen in Sweden. The region that you can see is only 12% of the total area of Sweden. So, and you can imagine the distance between the patient and the healthcare provider is huge. So it's very difficult to get to the primary care or the hospital on time. So this is one of the things that we are going to see how they solve it together with us in this region. So another region we are covering is much bigger than this in number of the population. However, we selected this customer interview with them, how they can see our solution and how we solve their pains. I think we can play the video. Thank you very much.
Thank you.
I think my time is
Thank
done.
you.
Yeah.
Thank you.
Thanks.
And now I'd like to invite Andrew Wilson from Elekta back on stage. Or Therese, sorry. Hey, welcome.
So thank you so much. I'm Therese Lindy. I'm Global Public Affairs Director at Elekta, and I'm happy to be here today and talk a bit more about what we're doing. You had my colleague Andrew Wilson up here before. And as you see, we're talking a lot about hope and bringing hope to people and working for equal access to care. And it's really, you know, images that all touches us. And I think we all have that story to share, that someone near and dear to us, or maybe ourselves, have been dealing with cancer. For me, that's my mom. She got diagnosed with breast cancer when she was 49, which is the same age as I am now. She got then ovarian cancer when she was 59, and she died just after turning 64. So I'm really happy to be here today and represent Elekta, because we all care. It's not just pretty pictures. So a bit more about us. We're a Swedish company, and we cover a great deal of countries across the globe. We're a very small niche, radiation therapy, so it's not too many companies. So we honestly do work with many, many cancer hospitals across the world, different cultures, different healthcare system, different everything. But the common goal is, of course, to improve outcomes for cancer patients. And we are really proud to say that we are touching about 2 million patients' lives every year. And that's, I think, is grand. Just shortly, there are many different kinds of radiation therapy. And it's one critical part of cancer treatment, together with other modalities. So here are some different of our product stories, but as you see, it's a lot about software nowadays, which is talking about the connectivity today. And I think what's mainly driven the development in radiation therapy is, one is the imaging. With improved imaging, we can improve the radiation, the targeting, and with that, better outcomes. But it's also the connectivity, that now we can do many, many things remote. It's remote treatment planning, it's remote services, it's remote everything, and that really open up for equal access as well. And there is a big need of better access to cancer care in general, but also for radiation therapy. And here you can just see, we talk about that 50% of all patients needs to have radiation therapy as part of the treatment. Could be standalone, it could be in a mix. Could be coming back many times because cancer is now a chronic disease, like we say. But if you see for breast cancer patients, it's almost 9 out of 10 patients that would need radiation therapy as part of their cancer journey. pathway. Lung cancer, almost 8 out of 10. And that's also the most common diseases or in cancer. So much needed, and that's why we go to work every day. And so in order to get that in place, it's not only to manufacturing a nice piece of equipment, but also to get it out there. And that's almost an even bigger deal because you don't do that alone. And it's really a team sport, as we say in cancer. You have to work together, many, many different parties. One important piece is, of course, the training and education. It's a lack of workforce across the globe, also in Sweden, for example. Service support, healthcare, financing, infrastructure, and this is all what we need to work with every day and what we also do. So very happy to talk more about this also after this presentation, and but this was just a snapshot of what we're doing and what we're trying to achieve. Thank you so much.
Thank you very much. Thank you. So next up we have Marie Öberg from Digital Diabetes Analytics.
So, hello again. I don't know, shall we watch the film first?
That's up to you.
Yeah, do so.
Yeah.
So, and this, I think that everybody here in the room understand now what continuous glucose monitoring is, and that you have used it within diabetes treatment and monitoring. And this company was founded in 2019, and the idea came from a person who has lived with diabetes almost his own life. And when he got the sensor, but around 2015, he started asking himself why his doctors and nurses didn't use the data as he had, because he could understand his disease much better when he got the sensor. He could see the graphs, but he didn't understand why his blood sugar and his glucose levels, why they jumped, or because I mean, as you know, it's not just the individual's metabolic situation, but it's also what you do and what you did, and it can differ from different times because it's so complex. So what he realized then, because he's an engineer and his name is Lars Cederblad, and he had time and he took the data and he started to develop. He started to code and developed a system. And then he took it to Per-Ola Karlsson, as we saw here before, who is a professor at Uppsala University and also works in clinical works at the hospital in Uppsala, and also one of his colleagues, Daniel Espes. And when he took this, when they saw what he had done, they realized that this is something as we can do something on, that we can develop a product. And that they did, and they did the research project in Uppsala with 800 patients, both children and adults, to develop and to train the algorithm. And I came into the company in 2020, because I have a background from healthcare since a long time. We work a lot with diagnostics, and I was part of Capio. It's quite a well-known big healthcare provider in Sweden and Europe nowadays, and I was part of that group when we started in the beginning of 2000. So I've been working with healthcare for a long time, but not being, I didn't come from the healthcare system when I started because I'm just a normal economist. But I've learned it from inside. And so that we have created now, that's what was said before, there's a lot of suppliers and developers, they don't understand what the needs of the healthcare and how it works. So we have created now a team with doctors inside, with people from engineers and persons like me and others, and also persons with a lot of experience from diabetes into the company. So we are about now 14 persons. And we decided that we should not just use the technology for the type 1 diabetes, but also for type 2 diabetes, and use it for diagnostic purposes, and use it for if you need. As you know, the persons with type 2 diabetes, they sometimes struggle to get a sensor, but they don't get it because the healthcare think it's too expensive. But the ones who can get it, they can then use the system to understand their disease better. And you can also use it. What we now tell to the healthcare, you can use this method as an intermittent monitoring. And you can change your way of working to define as the sensor, but we are not selling the sensors, but we need the sensors from the different providers to get the data. And so this is now implementing at some places and clinics in Sweden where they use it for the better treatment of type 2. And you can also use it to diagnose pre-diabetes, like in where we are now, which is a huge problem. And then you can use it, you test a person, and then you can see if you are in a risk or not. And then you have to, of course, to work with the behavior, as we were talking about before. And you can also, I don't know if you have seen it, but you will at least see it in 2 weeks when the Olympic Games starts, because almost all the professional athletes, they monitor their glucose data daily or quite often at least. So we are now also working with the Olympic Committee and the athletes to optimize their glucose level and help them to understand how to eat and change behavior to long laster. So we came from the academic and the university hospital side, where they use the technique and the systems that can use it to treat patients and people with the disease, but you can also use it for the consumers. And there are also today, there are a lot of companies today who take, and they use Abbott Freestyle Libre sensors, and they brand them with a batch, and then you can buy it from those companies, and then you get those graphs, but you don't get the analysis, which we do, because we take the data, we take the data and we make the analysis. So I presume that some of you have heard about Super Sapiens, Vera, etc. And the market is not overloading of those, and we think this is good, because it creates an awareness which can also then come into the healthcare systems from the not sick side to the healthcare systems. So this is what we are doing.
Thank you very much. So next up we have Claude Marcus.
Thank you. I will just give you a very short teaser of Evira, a digital childhood obesity treatment support system that we have used now for a few years. This is not any rocket science, it's quite uncomplicated. It's for testing at home and for providing information to the clinic. And it is basically a scale that the family with obese children have at home. What's special with that is that it's not presenting any weights to reduce the burden of weighing, which is for some children very complicated. And instead the data are shown in an app that the parents have and sometimes also the adolescents. And there they don't see the weight, they see the relative degree of overweight or obesity. And they are supposed to reduce their obesity. And if they're doing this in the correct way, they are in the green area in the app. Because children are growing. And as children are growing, you can't use absolute weights because they can gain weight and despite that reduce their degree of overweight or obesity. So they're supposed to follow that, and the data are also presented at the clinic. So the clinic can see in detail what's happening at home, whether or not they are doing these daily weight measurements, and if the weight is going down or not. And through this system, they can, of course, also easily communicate with the families. So they can act directly when things go wrong, or you can encourage them if things are going in the right way. So what we have done is that we have gone from process goals. Usually we have told the children and the families what they are supposed to do, but now we can tell them the opposite. You are supposed to follow these targets. If you do that, then it's okay, and you choose yourself the ways you do this. And you can also go from these intermittent checkups when you come to the hospital and often get quite disappointed, and instead of that you can have continuous monitoring and continuous support, and also individualized treatment in a totally new way. So the question is this effective? Well, yes it is. When we compare this with conventional treatment in Sweden, the results are twice as good as compared with what we have had before. And we can also see that if you use this type of system, you can treat twice as many patients as you can with conventional treatment. So this is quite recently become a commercial available product, but we have already 1,100 patient treatment years. And we have 180 or now 190,000 weight measurements and 6,500 messages. And the reason why this is important is because now we can start to use machine learning and artificial intelligence to identify patterns, to see what's happening at home when the children are gaining weight. That means that we can find the alarming signals that they are starting to fail already before weight is going up. And this can really change and further improve this treatment. This is only a very brief teaser of what we are doing. I think we stop there. Thank you very much.
Thank you very much. So let's move on to some digital participants. We have Francesco Masotta on the line again, I think, from Piloxa. Yes,
hi.
Welcome back.
Nice to see you again. A slide will pop up, but I don't need it for this one, for this thing at the moment. So let's jump back to the 14th century. Right now, if you are in the top 1% of the world population in wealth, then like you have access to reading, writing, and to knowledge and to build new knowledge for mankind. If you are in the other 99%, tough luck, you will probably never read a book. Until the printing press came. And what happened with the printing press is that suddenly there's a blooming of mass communication, of education, and millions of books could be read, and people could basically read, translate, and write, and there is the Renaissance coming up. So what Piloxa, which is a company I'm CEO and co-founder of, has been doing is that we are the printing press of digital health. You can think digital health right now is like books in the 14th century. You have to have, it's extremely time consuming to build. You have to have a large organization to support it. And there is just a few people that actually can drive it with success. We have been helping large organizations like pharmaceutical companies and large hospitals building their digital health, and especially the mobile applications for patients in specific therapeutic areas for several years. What we have done now is that we're taking all this knowledge and packaged in a platform that is both a technical, regulatory, and legal platform to enable any innovator to build their own way to interact digitally with the patients without having this large infrastructure. So for the first time, we are
oh no.
And you can hear me? No.
No, I think you're back again. We lost you.
Yeah, maybe.
Yeah.
Okay, but it's okay. So basically, we have been taking all our knowledge into building blocks, and every innovator can now put together building blocks in their own way to generate digital engagement for patients, build their own mobile applications, and then learn from that. So transparent and affordable pricing, just go on the website, you find it there. Patient functionality added each quarter and always available to any user. Unlimited updates, release in a month. So what I want you to get out of this presentation is, digital healthcare is now possible to drive for anyone. So if you have an interest in patients and you think you can engage digitally and deliver value, speak to us. The second thing is that you don't have to take my word for granted. Try it. So if you have a project, you just send a mail to me or go to the website, and then we book a 2-hour workshop. Within a week, you get a tailored demo application that you can try by yourself.
Oh, I think we lost you again.
Free of charge. Free of well, see, hey, I'm trying to turn. If I turn off my camera, you still hear my audio, so that's good enough, I guess.
Yeah.
So try it yourself. Contact us. Have a 2-hour workshop. You get a tailored demo application to test for free in a week based on your needs, and there is no strings attached. Full value upfront. We want to make sure you feel comfortable driving digital innovation. So that's why we do that for you. So basically go to piloxa.com, look at the pricing, write us a mail, and in a week you get something in your hands that you can actually test. Thank you so much for hosting us at this event. It's a pleasure speaking to you.
Thank you very much. So let's welcome the last but not least, Anders Sonesson from Gluco. Do we have him on the line? It's never a good sign when the technicians shrug their shoulders. Oh, there you are. Welcome back.
Oh. Can you hear me?
Yes, we can. And we see you.
Okay. Thank you. It's a classical COVID question, right? Can you hear me or can you see me? See my screen? Should I use this clicker now to go with it? You don't have my presentation there?
We see your presentation.
Oh. Thank you very much. So, thanks again hosting me, having me here. My name is Anders Sonesson, based in Gothenburg in Sweden. So back in 2005, me and some friends started a company called Diasand in Chalmers University in Gothenburg. That was the idea of working in diabetes, collecting data from different sources in a unified way. So we ran that to 2016, and then we were acquired by a company called Gluco. So that is the company name today, but in the past in Sweden and in many other countries, it has been used as Diasand. So who we are? So we are Gluco, and we transform digital health by connecting people with diabetes to the healthcare professionals. So with that, we hope to improve communication and have a lot of more collaboration. So the base for that is that actually we take a lot of data from different sources in diabetes. If you have an insulin pump, CGM, and so on as well. And my presentation was, it's easy to do now when Marie did a lot of good background information for diabetes. So I don't need to spend a lot of time on that, but that was a good background from that as well. But I will talk about that briefly anyway. But so today we have more or less 3 million patients on the system, more than 7,000 clinics around the world in 29 countries and 22 languages. So we think that we are one of the biggest data management solutions in the world at the moment. And we have offices in US, France, Germany, UK, and in Sweden. So some short information about challenges in diabetes management. I think during the day we have learned from different sources here that about diabetes. It's a very typical chronic condition and digital health concept. So with all the glucose readings you have, as I said, 15 years ago, it was we were happy if we could have 4 readings a day from a patient. Now we have more than or close to 300 data points in glucose reading. So we need to have a big and a good data management for healthcare there then. So other challenges is that, okay, how should you read the data together with your healthcare professional or by yourself? You have a lot of different devices, and we see a lot of data management solutions come from a specific device, but if you get that in one view and then data from another device in another view, that's quite complicated. So that's our main focus, that we would like to unify the data. And of course, adherence in diabetes is a challenge, and it's a complicated disease to have, and it's not easy to follow all the things you should do in this world. And how could you work with patients remotely and so on as well? A lot of challenges. Now I change screen there. Sorry, I think I lost my. Yeah, okay. So what we do, we help out with all that, with the glucose levels and insulin data and so on as well, enable telehealth and remote care, and then we also streamline the clinical workflow, meaning that if a patient comes in, we take the data from their devices as well and give to the healthcare providers. So with that, I would like to say that we are trying to be a system for, could be at home doing remote care. We could also be in the clinic working in that setting. And as I said earlier in the panel, that before COVID, we have 70% of all our uploads from devices come from in the clinic. Nowadays, it's much more 70-75% coming from home. So that's a big change. So from home, uploading all the data from different meters, CGMs, BGMs, or blood glucose meters, and then insulin pumps. We see more and more devices coming with connectivity. One of the things is that insulin pens nowadays will also have a connectivity, and we are spending a lot of money to integrate that to the system as well. And then share the data with the clinics so they could easily read the data as well. So this is a difference that we do compared to the presentation, Digital Health from Marie, that they are doing fantastic, great analyzing of the data in that way. We're doing some analysis, but we are mainly focusing on the total system, that we're adding remote care, adding other features, sharing data, and so on as well. Trying to have that as a foundation to our business and work with other companies or institutes and so on, so with this as a system. So that's a difference, that we're trying to be the #1 on the device integration, having from, if you have 4 or 5 insulin pumps on the market, we would like to work with all of them and gather the data. So that's what we spend a lot of time and money on. So yeah, and at the end of that, we visualize all the data in graphs for healthcare providers and for patients. Also spending now in the next years with some other diseases as well in chronic care, but now a lot of focus on diabetes. But we will add more business units to the company going forward. So that's all for me. Thank you.
Thank you. And to round off this very interesting day, we have a few final words from Nasim Bergman Faroknia, the chairwoman of eHealth Doctors Association in Sweden. Welcome back.
Thank you very much. Really, I'm so honored to be a part of this event, even if just a small one. And there have been a lot of inspirational and very, very wise words during all the hours you've been holding this event. So I just want to have a brief summary here. As we've heard, today we are facing challenges for our healthcare systems globally, actually. So using digital technology and all these digital tools is for finding solutions for our challenges. It's about accessibility, uneven supply of skills, inefficiency, but also demography and geography. I mean, within rural areas, we have, of course, our medical deserts, and otherwise there are a lot of waiting times when there are a lot of people waiting for different kind of healthcare actions or accessibility. And of course, we have our global megatrends of urbanization and digitalization. So the pressure to change is high. I try to go to the next slide, but it seems like it's not working, or maybe there is a delay. I don't know.
There might be a delay. You skipped a few slides now.
Yeah, I see, because I've been pressing a lot. So we need to go back. Maybe it's easier. Yeah.
And now we have an eHealth with the star on it.
One.
Yep.
Yeah, back. Okay, this one. And this is definition of eHealth. I mean, we can start with the definition of health. This definition is from World Health Organization, WHO. Health is physical, mental, and social well-being. So the complete picture around every individual or patient. And eHealth is to use digital tools and to exchange information digitally in order to achieve and maintain health. So it's the prevention we've been talking about the whole morning here, and of course, empowerment. I just wanted to share with you, I mean, obviously, you're aware of sustainable development goals, and the whole Expo area just breathe this with different kind of both information, knowledge, and also giving tools to people to understand it even better, and how we together can contribute to bringing in more of sustainability, both in now and for the future. And of course, we can use digital tools to contribute to some of these goals, both access and equal healthcare, for example, or bring in more of knowledge to our users, as we've been speaking about. So it's about the access is about democratization, and of course, again, about empowerment. And why data is important, just a reminder that we need innovation, and of course, we need data. For example, through these kind of wearables, I have a smart watch, or when we have different kind of devices or gadgets, when an individual gathers data and send the data into healthcare professionals to co-create. But we can also use the data for iterate and to continuous development of all, both hardware, but of course, those services we build around the individuals, and how we connect healthcare professionals with individuals. And using digital technique, we can also bring in more from less. So that's a less impact on our environment and our sources out there. That's why I just wanted to exemplify with the book. And if you are interested, there are a lot of podcasts to listen to from Stanford University, different aspects of sustainability, and how we, from different competences, can collaborate to move the whole innovation forward. I'm waiting for the next. I think there is a delay in.
Yeah, we see it. We see digital healthcare services in Sweden started as a disruption.
Very good. Thank you, Britta. Yeah, and this is also a kind of reminder. I mean, as you can see, the disruption level, it's on the y-axis, and the timeline is the x-axis. And the digital transformation started in other sectors, of course, and there are a lot of technical innovation that we can bring in from sector to sector. So healthcare sector has been kind of a bit behind, and of course, a market innovation, I mean, how to finance or reimburse these services is a key to build also companies around innovations and to scale the companies, of course. So that's the next level of this disruption. And the third level, and maybe the one that takes the most efforts, is the social innovation, because it's about new roles both for our users / patients, and also for healthcare professionals, physicians, nurses, physiotherapists, nutritionists, because as we say, individuals need to track the data and then send the data. So the technique we have, but being in a agreement to do that, and this is a new ways of working. And one thing is to give the tools and to empower both parts, and the next is to kind of getting over the obstacle to actually use these tools. And when something is new, because me, for example, I studied med school 25 years ago. So, and a lot of education is still very traditional and kind of 100% physical. Even if the pandemic, I'm going to speak about that too, kind of opened the doors for many people, even those more skeptical, to actually try and test all these new innovational ways of working and all the tools. So as we need new regulations to also protect, both to enable and to protect, of course, we also will need leadership and courageous leadership to actually support all these different roles to moving forward, of course. Yeah, and the future healthcare is already here. We can do it more personalized. And when we talk about data and how to interact and communicate to interfaces, the user patient and the user healthcare profession, we also speak of patient-reported outcome measures or patient-reported outcome experience. And these are data we can use both to develop our services, but also for research. Because as you know, we can also get very enthusiastic, and the number of new apps and new solutions kind of raised all the time. So we also need to study to find those best practice solutions, especially in Sweden. I mean, we use taxes money to finance or grant most of healthcare. So it's very important to use the money, our common resources, wisely. So that's also very important impact. But also using data to be precise and preventional, as we've talked. And it's, of course, about very much chronic disease management, but also diagnostics in emergency situations. And this is an example of, you know, there's been a pandemic for the past almost 3 years. And that was the final example, or a very decisive example of the patient nowadays is the point of care. We've been doing a lot of home testing to diagnose if there is a current COVID infection or not. And everybody's been doing that. And we've been doing that, sharing data and all the time improving these test kits regarding accuracy, for example. So that's been a good trial period and educates all the users on both ends. And for the last one, sharing some knowledges from Sweden, what we've seen. I mean, the scaling of the solutions happened very rapid because we simply needed that. So all 21 regions in Sweden, they've introduced or scaled rapidly digital care services. And for example, region of Stockholm, the largest region in Sweden, their own app, Always Open, showed an increase by 1,000%. It's huge and impressive, of course, very impressive. And the use of digital symptom checkers, digital triage, home monitoring, home tests also sharply increased. And even among private providers, e-health tech companies, and there are some examples here, they've also had a huge impact, both in the disruption start of this whole revolution or evolution, but also all the time pushing it forward. So with these words, thank you again, and I hope that we continue to contribute to this transformation, even if the pandemic soon will be gone. Thank you very much.
Thank you very much. And with that, we would like to conclude our day here today. Thank you, everyone, for joining here and online on the live stream. And thank you to all the panelists joining here today. Thank you.